Here we are. So, good evening, everybody, and thank you all for finding time and joining today's webinar. Home Sweet Home, keeping HBV liver transplant patients safe from viral infection and compliant to therapy. By attending this webinar, you will learn how liver transplant patients can be maximally protected from HBV reinfection, as well as from COVID, by switch them to subcutaneous HBIG, and how to improve patient quality of life. I am Paolo de Simone from Pisa, and I'm very pleased to be joined by two excellent speakers. The first will be Jean Hardwigsen from the Liver Transplantation and General Surgery Unit, Latimona Hospital in Marseille, France. And the second will be Riccardo Volpes from the ESOT institution in Palermo, Italy, who will soon give insightful presentations relating to this important and timely topic. Each presentation will last approximately 20 minutes, and there will be a question and answer slot when both presentations are complete. To facilitate the question and answer, you should be able to see a question and answer option on your screen. All attendees can write and submit their questions, which will be seen by the speakers and myself. I will then read out the questions, which will then be answered by the speakers and I verbally during the question and answer session at the end of both presentations. Whilst the question and answer will occur after both presentations have taken place, we strongly encourage you to post your questions throughout the webinar when you think of them. And we will do our very best to answer all questions in the time provided. This webinar is supported by BIOTEST via an unrestricted educational grant. We would like to kindly ask that all participants place their city, country, and specialty into the webinar chat function. You are welcome to share details of this presentation responsibly and with due credit on social media. Now I will introduce the first speaker, Jean Hardwigsen. The corona pandemic has slowed down a number of liver transplant procedures with prioritization given to essential cases to give hospitals more capacity to prepare for COVID patients. Jean will provide insight into how this pandemic has impacted transplant patients, followed by his experience from France on switching patients and changing guidelines for access to medication. Without further ado, I will now hand over to Jean. Please, Jean.
Hello, everybody. Thank you very much, Dr. de Simone. I'd like to speak, I'd like to speak about how to keep patients safe. I'm sorry. I have nothing to declare. First of all, as you know, there is now an important consequence of COVID pandemic. Global mortality in France increased dramatically. About 15% of persons die during this period. There is a lot of variation between areas. The north of France and the east of France were particularly impacted by this viral infection. In Marseille, in south of France, we have observed about 10% more mortality and death. French government declared an emergency state from March 23rd to July 10th. A COVID policy was applied in all public hospitals. Several emergency rooms and intensive care units were dedicated for patients with a COVID infection. In consequence, during this emergency state, there were a dramatic reduction of organ donor available. As you can see on this chart, the comparison between France and USA was different. Global transplantation procedure in France decreased proportionally as the number of COVID infection patients increased. You can see on the chart. In consequence, all departments of nephrology stopped kidney transplantation. In US, there were less decrease in number of transplantation. Moreover, there were a change in liver transplantation policy. Liver transplantation in France were performed only for acute liver failure, fulminant hepatitis, or for oncologic risk of dropouts. In consequence, we applied for liver transplantation patients the following policy: to stay safe, stay home. There was an adaptation of a non-urgent follow-up consultation plan face-to-face. We start video or audio consultation and recommend, if possible, therapy at home. Stay-home policy reduces the risk of acquiring COVID-19 infection in the hospital by caregivers or other patient contacts. Stay-home policy also reduces resource and infusion ward requirements. What about our experience with liver transplanted patients for hepatitis B infection? As we know, after liver transplantation, hepatitis B recurrence can lead to a more aggressive course of infection, graft dysfunction or failure, or death. HBV recurrence post liver transplantation decreased dramatically over decades. This decrease was related to a large use of human immunoglobulin against hepatitis B virus, alone or associated with lamivudine or high generic barrier nucleoside. Hepatitis B immunoglobulin therapy was recommended by national and by international guidelines, in particular in case of high-risk recurrence post-liver transplantation, as when detectable HBV DNA at time of liver transplantation, in case of co-infection with virus D, in case of concomitant hepatocellular carcinoma. What's about the mode of action? HBase antigen is not targeted by a regular antiviral. What is this antigen? It's a surface protein on virus B or virus D. It's required for virus to entry into hepatocytes. HBase antigen seropositivity is associated with three main processes. First, the suppression of anti-HBV immune function by T cells, a pro-inflammatory state, and a higher risk for hepatocellular carcinoma. Usually, antiviral monotherapy does not eliminate this antigen seropositivity. For many years, as many other centers, we use intravenous injection of this immunoglobulin to prevent recurrence of HBV. Since 2015, we progressively introduced a switch with this IV therapy to subcutaneous injection. As you can see, this alternative route for administration is potential benefits with equal pharmacokinetic distribution in organism. This protocol is or every week's injection or every 2 weeks injection of a single dose of 500 or 1,000 international unit injection. The goal is to get a HBs antibody level in the serum upper than 100. Usually, the switch from IV form to a subcutaneous form is starting 1 month after the last injection of IV, and as usually 1 month before the next one. Before each injection of subcutaneous, we perform a HBs antibody titration during 1 month. Then, after, we do this monthly. Adjustment therapy was as follows. In case of HBs antibody titration between 100 and 500 international units per liver, no change were done in the level or in the frequency. In case of HBs antibody titration less than 100, we increase dosage to 1,000 per injection. In case of HBs antibody titration upper than 500 international per liter, we decrease the frequency of injection every 2 weeks or every 2 weeks or every month. These procedures were reported by Didier Samuel in an European study called ZES. 49 patients were enrolled. What we observed is that no recurrence was detected. All patients were negative for HBs antigen and DNA of this virus. All patients' antibody level were upper than 100 international per liter. The only serious event was a minimal hematoma. No serious event was observed in this series. Its conclusion of the series was convenient to use, an increase of quality of life for subcutaneous administration, well-being of all patients, a better compliance, and a log-like adherence for this prophylaxis. You can find in this table the main side effects observed. All of them were rare or very rare, as headache, tachycardia, hypotension, nausea, or arthralgia. Another interesting benefit of subcutaneous injection is the possibility of self-administration. In your team, explanation and demonstrations were performed by a nurse. How to prepare a syringe, how and where to perform a subcutaneous injection with a demonstration kit. First tests were performed in hospital treatment room under the surveillance of a nurse. It's easy to prepare. Self-injection and nutrition guide were provided to patients with insulated bag and a patient book. We offer for all patients documents, phone numbers in case of problem, links to video or tutorial movie, and tools for patient education. First of all, pre-filled syringe was available with a single dose of 500 international units per milliliters. It's easy to perform, and this education was very safe. We provide for patients this map of possible subcutaneous injection, and we recommend them to alternate injection to prevent lipodystrophy. Our experience was that the therapeutic education carried out by the consulting nurse, 1 or 2 sessions is sufficient in most cases for patients to be autonomous. Tolerance is excellent, consistent with already clinical data published. Monitoring of plasma level of anti-HBs in the medical analysis laboratory of the city was possible, and transmission of results to the liver transplant unit is routine. We obtain more stable serum anti-HBs level for lower HBs anti-immunoglobulin dose. In conclusion, so this protocol for us is this protocol offers patients more autonomy and promote a better quality of life, facilitates therapeutic adherence, and decrease the risk of nosocomial infection and others like COVID-19 infection. Essential medication is delivered without the need to get in contact with hospital staff or other caregiver and other sick patients. Now everything is done at home. Deliverance of therapy and blood prevalence for analysis. Positive impact is also to reduce hospital and health spending. In fact, as already published, self-administration is possible for more than 19% of patients very quickly. Difficulties is observed with old patients or with patients with a long-term experience with IG procedure. It's, as we call this, a fear to change. Another indicative thing is that it's less cost for hospital. In case of weekly injection of subcutaneous injection, it was estimated worth 10,000 euros. But as I already talked, after a few months, it's possible to deliver this therapy every 2 weeks or every 3 to 1 month. In this case, it will be cheaper than IV procedure. These results are already published in the French meeting. In conclusion, what we can say is that prevention of HBV recurrence using a self-administration subcutaneous injection is effective in most of the patients, easy to teach, only 2 sessions, and cheap. Of course, we can tell that it's efficient to protect patients in case of confinement due to respiratory pandemic in our case, and maybe in the future for other infection if it's come back. I would like to thank you and of course answer the questions.
Thank you very much, Jean, for your presentation. It was very interesting to me, at least, also the opportunity to compare data on the COVID epidemic in France and with data we collected in Italy. Very, very, very interesting. I would like to remind all participants, because it seems to me that some participants are placing their questions in the chat box. Please do put your questions in the Q&A box, which is a button at the on the lower tab of your screen, and just indicating who you are, what's your specialty, and what's your country, what your country is. Now, thank you once again, Jean, and I will now, it is my pleasure to introduce to you Riccardo Volpes, a colleague and a friend of mine, who will deliver from Palermo, from southern Italy, the second presentation of this webinar, Riccardo's presentation will focus on how liver transplant patients can enjoy an improved quality of life while being adherent to their therapy and also avoiding viral infection. Over to you, Riccardo.
Well, hello to all people here. Good evening. Thank you, Paolo, for the presentation. I want to thank BIOTEST and ESOT for the invitation. I have no conflict of interest to declare. We are speaking on prophylaxis of hepatitis B. Just a short introduction. The reason why we are still transplanting patients for hepatitis B indication. You know, there is around 15–20% of indication for liver transplantation for hepatitis B, plus or minus delta severe infection. And this is our casuistic in which by studying the retrospectively, we see still around 18% of patients undergoing liver transplantation for this indication. We are speaking of prophylaxis against hepatitis B reinfection because we all know that hepatitis B is a DNA virus which integrates its DNA in the host genome, and therefore there is not only the liver infected by this virus during the natural history of the hepatitis B chronic infection, but many organs in the body. So the reason why after the transplant there is a rapid and quite early reinfection of the graft since the virus is moving from the extrahepatic sites where the virus is integrated, and therefore, as you see in the cartoon on the right, the reinfection in terms of time is quite early after the liver transplant. There is a short, a brief phase in which there is a down of the liver, and then immediately after the transplant, in the few days, there is in patient, of course, without any prophylaxis, there is hepatitis B recovery. This is the reason why, since early 90s, there was a study of looking for preventing this hepatitis B reinfection. And as you know, the first product appeared was the HBIG, and the professor, the talk before me already spoke about this. And therefore, there was a pipeline of new antivirals starting from lamivudine, then entecavir and tenofovir, and the two orange entecavir and tenofovir are the current very strong new generation of antivirals that we use in combination with human being for preventing the hepatitis B recurrence after liver transplantation. The introduction of the human being and then of the new oral antiviral changed dramatically the survival of this patient. As I told, after transplant in patient with no prophylaxis, there was a clear-cut rapid hepatitis B reinfection at the early of the 90s years. And then once the prophylaxis started, there was a completely improvement of the outcome of this patient with a survival curve that is actually one of the best after liver transplantation. And this is what we are now using as a policy. You see that the patient with hepatitis B viral infection, cirrhotics, or hepatocellular carcinoma usually start the antiviral treatment before liver transplant with the goal of arriving to a liver transplantation with no DNA, hopefully. And then immediately after the liver transplantation, we keep the oral antiviral treatment with no change, and then we start the combination prophylaxis by introducing a human being immediately after transplantation with the goal of keeping DNA of the virus completely negative in the long-term time after liver transplantation. This is our protocol that is shared with many other centers in the world. You see the patient hopefully undergo a liver transplantation without viral replication. And then immediately we start a human BIG in the anhepatic phase during OR, and then we maintain the intravenous administration of the human BIG for the first week. And then in day one after transplantation, we also keep the same oral antiviral that the patient was taking before liver transplantation. Our protocol focus on the long term also. You see that we keep long life the oral antiviral, and then we give human BIG very in a minimal amount, usually 1,000 units per month, with the goal of keep the anti-HBs titer in between 50 and 100, because the study that we are now available usually try to demonstrate a higher anti-S titer, but this was shown with lamivudine that is more weak than the new one. So we feel that with the new one and tenofovir, there is the possibility to maintain an HBIG in administration with a minimization of the dosage. With this prophylaxis, we are proud to say that we have no HBV recurrence after liver transplantation, and therefore the survival curve of this patient is actually better than the other indication after liver transplantation. And we speak about survival of this patient usually, but, and this is the argument of today, is the quality of life that by having a higher number of patients, a big cohort of patients after transplantation, we have thousands of patients now that we are following up in the last 20-25 years with the improving of the survival. So the focus on the quality of life of this patient is absolutely important. And the third point of this scheme is also look at the cost of the management of this patient. And the term of adherence is just in this setting. So adherence, it means that patients should keep on correct treatment by minimization, if possible, drugs and strategies, and then improve his lifestyle just for improving the quality of life. Going back to the hepatitis B protocol, you see that about human BIG, there was an initial phase in which we had only available human BIG intravenous administration. Then in 2006, we had the opportunity to switch patient to intramuscular administration of the human BIG. And in the last 10 years, we have this subcutaneous human BIG product, which is the Zutectra. We had an early, we are now in our clinical practice had the opportunity to early convert this patient to the subcutaneous administration. Usually we give, as I said, intravenous in the first week. Then we have a window of 3 months with no administration because of the large amount of antibodies given in the during the operational phase, and then we start the human BIG, as I said, 1,000 subcutaneous monthly, and then we adopt a fixed schedule. We don't usually don't measure the anti-S titer in such patients because we feel that the combination is so safe that we leave the patient by himself to decide which time of administration to give. So if once a month, twice a month, or once a week. As my speaker before said, that the advantage of Zutectra are several, but the two most important and this is the reason why the patients are most in favor of this use of subcutaneous human BIG administration is the less pain during infusion in comparison with the intramuscular, of course, product, and the possibility to have a self-administration, so the patient is completely self-managed in this. And then we just to focus on the quality of life of this patient, recently we published this article in which we measure the quality of life of this patient during the time that they switch from intramuscular to subcutaneous. And then we give two questionnaires. The first one is SF36, by which we show that the pain related to the quality of life was improved for switching from intramuscular to subcutaneous. And in general, also the psychological approach to the new treatment was absolutely improved in this setting of patient. If you go further in the many variables that were administered to the patient, in the second questionnaire, you see that side effect during the injection was absolutely minimal. There was an improvement in flexibility in managing this treatment. Of course, there was perception that no need of support is indicated for this self-administration of subcutaneous product. So it was an overall satisfaction with this treatment, which was statistically significant. So the take-home message of this paper was that the gold standard remained combined prophylaxis. The anti-S titer should be kept around 100 using Detectra with different schedule of administration, and then the quality of life improves by using this subcutaneous administration route. So for conclude, I think that now we are following up 100,000 of transplanted patients. We have not only to focus on the amount of time that this patient survive after transplantation, but of their quality of life, which is focused mainly on adherence. So the patient should be adherent with the suggestion of the physician, and in general, this adherence means also minimization and keep the treatment the easiest way possible. We have to pay attention to the psychological issues after years of liver transplantation, but also schooling of this young patient is important, and to go back to their employment. So in general, the improvement of lifestyle, nutrition, and physical activity is probably the new goal of our work in trying to improve quality of life after liver transplantation. Thanks a lot, and give back to Paolo and Simone for the conclusion.
Thank you. Thank you very much, Ricardo, for your presentation and focusing on your schedules, the ones you adopt at your center, and also on the issues related with quality of life in this category of patients. We will now move to the question and answer session. And as mentioned earlier at the start of this webinar, you should be able to see a Q&A box at the bottom of your screen. You can write down your questions and submit them, and they will be seen by ourselves and myself. I will then read out your questions, and the questions will be then answered by all the speakers and myself verbally. Just to start with, I would like personally to put a question to Jean. Jean, has the situation in France regarding to COVID come back to normal, or are you still suffering some limitations due to the COVID epidemic?
For this question, in France now it's not normal, not yet normal. We see in June, in the beginning of July, a decrease of COVID infection, but now it started again, and we keep patients at home if possible. Few patients in hospital, of only if necessary.
Okay, thank you so much. And regarding your presentation, if I'm correct, you mentioned about the possibility to switch patients from intravenous to subcutaneous formulation. Do you have any experience with, or does the same algorithm apply for switching patients from the intramuscular to the subcutaneous formulation? Because at least here in Italy, the majority of patients currently treated in their post-transplant follow-up are on intramuscular immunoglobulin formulation, I would say. Do you think the same algorithm might apply, the one you presented might be applied for patients on intramuscular formulation as well?
Till now, we do not have any experience with intramuscular. We only use IV or subcutaneous. So we don't try intramuscular because we switch for subcutaneous immediately when it's appeared.
Okay. Riccardo, probably you had much more experience with intramuscular here in Italy. Do you think the same principle might be applied, switching patients from intramuscular to subcutaneous? Or what do you do?
Yeah.
You should switch a patient from the intramuscular to the subcutaneous formulation.
As showed, we start with an IV injection during the peri-surgical phase, and then we switch the patient to parenteral, which means we leave the patient free for his decision to use intramuscular or subcutaneous. We explained the two different formulation because we in Italy have availability of both. And then the patient usually decide which one is his favorite, because we know that both preparation have almost the same efficacy in terms of prophylaxis. And we register that most of the patients currently decided to use subcutaneous formulation because of the clear advantage that we showed in our presentation. And most patients also decided to switch from IM to subcutaneous formula, also because they understand some benefit in this switch. As I showed, historically, we had a big impact in switching from IV to IM, which was not easy because the patient had facilitation of coming to the hospital to do intravenous administration. So the first switch at the time of appearing of the IM formulation was difficult to convince the patient to do the same prophylaxis at home. Now to switch from IM to subcutaneous is easier in terms of, as I said, convincement of the patient.
Okay, thank you. Jean, during your presentation, there was a question for you, which runs, at which site you inject antibodies subcutaneously? Is there any site preference when you educate or train your patients?
For education, we show to the patient the easiest way, which means it's the skin of the abdomen, because with the two hands of the patient, and it's easier to use this way. After, we recommend shoulders of anything else. Of course, the back of the body is difficult, and the patients need the help of somebody of his family usually. So in the beginning, it's the easiest we recommend.
Thank you. There is, scanning through the Q&A box, there is the $1 million question that I'm gonna put to both of you. Are you considering withdrawal, immunoglobulin withdrawal? Yes, no, and if yes, for what patient? In order to be neutral and just to capture all the evidence reported in the literature, you know that there's a lot of consideration about the possibility to withdraw immunoglobulin. What's your feeling, Riccardo?
So, according to the more recent protocol by international societies, we have divided patients into big categories, low and high risk at the time of the transplant. And the recommendation is that in patients undergoing liver transplantation in the low risk category, you can keep human big for 1 year and then try to withdraw. So by keeping, of course, the oral antiviral prophylaxis. And you all know that the data published by James Fang in Asia show this very good survival after transplantation by using only oral antiviral. So I think that in patients with a low risk of recurrence, it's feasible to try to withdraw immunoglobulin after a while, I would say 1 year, as recommended by the International Society recommendation. If in our convincement, we keep the combined prophylaxis in all those patients with so-called high risk, means the delta hepatitis co-infected patient, the hepatocellular carcinoma patient, the patient undergoing liver transplantation with HBV DNA positivity. So there is a stratification of the risk at the time of the transplant, and then on that basis you can decide.
Okay, and what's your feeling about that, Jean?
We thought about withdrawing this immunoglobulin in case of hepatitis B fulminans and after 1 year. In those cases, for me, it's very difficult to withdraw this therapy because it's very effective. Now we adopt the 100 international units per liter as a goal in the beginning, but maybe after many years we can go down 50 or less. In one case, I think it's very difficult to stop. This case is liver transplantation for hepatitis B associated with hepatocellular carcinoma, because we observe even later a recurrence in case of carcinological recurrence in particular. So in this case, I think withdrawing is impossible.
Okay, if I'm correct, neither of you think that, I mean, neither of you uses a totally ab initio immunoglobulin-free schedule.
Sorry?
Neither you use immunoglobulin in your patients, modulating the length of time according to their risk, but you use immunoglobulin right from day 0 in your liver transplant patients.
Okay.
Is that correct?
Yeah, yes, is that correct?
Okay, okay, at both your centers, if I'm correct in understanding, if I'm understanding you correctly, you don't use a totally ab initio immunoglobulin-free protocol.
Yeah.
Okay.
No.
Because there's one question in the box. So could you just remind the audience what the criteria are for high risk and low risk category of patients, HBV patients for liver transplantation, and how you modulate your immunoglobulin exposure according to these patients? Some categories you have just alluded to, for instance, hepatocellular carcinoma. But do you stick to the ESOT rules? Do you stick to the what kind of criteria do you use in your practice for high and low risk patients?
So for high risk people, our risk of recurrence is people with B and D infections, people with a time of liver transplantation DNA positive, and people with hepatocellular carcinoma, and people with HBV co-infection, and the other is with discussions. For this patient, we follow the recommendation with, in the beginning, high frequency of injection, which meaning every week injections.
Okay, and for you, Ricardo?
Well, I do agree. Those are the categories, but if you see the recommendation of the ESO, American Association, ELITA, both are all the same. Now there is a large consensus in stratification of those patients. Are more, I mean, in general, those are the categories on which is recommended to keep long life the combination prophylaxis, and the other categories, the low-risk patient with no viremic at the time of the transplant, then all are agree with trying to withdraw after 1 year. So now it's difficult to find a conflict in this opinion, at least now.
Okay, thank you. Ricardo, back to you. Is there, according to you, is there any role for vaccination and post-transplantation for HBV patients?
Well, we had, some years ago, there was an attempt to vaccinate such patients after transplantation, before and after transplantation, but with no results, at least by using those vaccines that were available at that time. So this philosophy to vaccine the patient after transplantation has been abandoned now. Can be recruited if other kind of vaccine will be available in the future, but as far as I know, there is no center that use vaccination as a prophylaxis strategy, I think.
Jean, to you, a question. What is the best or the optimal level titer of antibodies, the one you target in your presentation? And it seemed to me that probably you target around 100. What is the best or optimum level in your experience at your center?
In your center, we do not use booster dose, and answer for the vaccination, we don't use vaccination because our experience vaccination is very poor. It's not very performance. Sorry, I forgot.
What's your titer?
The titer?
Yeah, the target titer. Is it the same throughout the follow-up, or it depends on the follow-up period timing?
In the beginning, our titer is 100. The goal is 100, and after 5 to 10 years, we decrease to 15.
And in your center, Ricardo, is it the same?
It's the same. So year by year, we are trying to keep the titer around 50, 100, in between 50 and 100. I mean, so far we registered no HBV recurrence by keeping this titer lower than demonstrated in the literature, at least. And this because probably the entecavir and tenofovir are so strong in terms of efficacy that may allow to minimize the human big dosage. And this is also good in terms of general cost of management of this long life prophylaxis.
Thank you. Jean, there is one very interesting question I would like to ask you on behalf of one anonymous attendee. Is the subcutaneous application only a temporary solution so that patients don't have to come to the hospital for COVID infection, or do patients actually prefer subcutaneous immunoglobulin over the other formulations, in your experience?
So during COVID infection, it was very difficult to perform an education. So there is unfortunately a stop of education during this period. For me, COVID infection is probably a starter to increase the switch for everybody and to recommend this switch for people, all people, and people who are fear for change.
Ricardo, one very intriguing question to you. What is the reason to continue HBIG immunoglobulin lifelong for hepatocellular carcinoma patients?
Those patients that are considered at high risk because by the risk of repositivization of HBsAg in patients with only antiviral is considered a risk of HCC recurrence. Since there is no clear-cut evidence that only antiviral prevent hepatitis B infection in those hepatocellular carcinoma patients, and since there is evidence, in contrast, that combination prophylaxis prevent, at least so far with the data so far available, the HBV reinfection in those patients, the general strategy is to keep combined prophylaxis. Of course, some patients with only antiviral prophylaxis in the series by fund maintain the HBsAg positivity after liver transplantation in spite of the hepatitis B DNA negativity. But the correlation of those group of patients with the risk of HCC recurrence is not known. So there is a general consensus that to keep those patients in the safest protocol available now, which means combination protocol.
Okay, thank you very much. There is one question, Jean, regarding COVID, and the question is just how to test, how to be sure that the donor and recipient are COVID-free before transplantation, and what's your protocol or algorithm at your institution? Are you transplanting organs in COVID positive recipients? Are you transplanting organs from COVID positive donors? What's your algorithm? What's your position?
So in France, since the middle of March, every donor was tested for COVID. And in case of COVID plus, the donor was not proposed for transplantation, liver or other organs. So for recipients, till now, we do not have to transplant people with COVID plus PCR. I think if it's necessary, we do it in case of people without any respiratory symptoms. So each people before liver transplantations is tested as for other surgery, is tested with PCR with for COVID. And we know that until now we do not have transplanted such people.
Okay, well, Riccardo, what's our policy in Italy? Would you like to recall our policy in Italy, which is very similar to the one in France in terms of COVID?
Well, in terms of, we have no impact in terms of immunoglobulin, you mean hepatitis B prophylaxis during the COVID year?
What are you going to do for COVID?
No change. No change in terms of treatment, no change in terms of prophylaxis. The protocols and the scheme remain the same. We had the advantage of use already the parenteral administration of the human being. So we had no problem in terms of don't let come the patient to the hospital, because 100% of our patients already did a human big prophylaxis at home. So this was not, this had no impact in terms of management with this particular aspect during the COVID phase.
Yeah, thank you. Thank you again. Ricardo, there's one question I would like to put to you, because in your institution, you also perform, not you personally as a hepatologist, but you also perform other types of organ transplantation. So what's your policy for kidney transplantation, for instance, antigen S positive kidney transplant patients?
If the recipient is a hepatitis B positive patient, the recipient is treated with oral antiviral alone at the time of the transplant. Usually we use lamivudine because for those patients there is a very low risk of hepatitis B recurrence, but we don't use human BIG in those subgroup of patients, not liver transplant patients. With this strategy, we have a number of transplanted patients by kidney, heart, and lung with no recurrence by using only oral antiviral prophylaxis after transplantation.
Okay, thank you. Jean, my very last question to you. Do you use livers from surface antigen positive donors?
Yes, we use this for people we are, or in case of emergency, hepatitis filmentis, or risk of dropouts. In such case, we use after this prevention with subcutaneous injection. And usually we prefer to use this such liver for people who are hepatitis B positive. And because after this, there is not a main change. There is a same prevention with perfusion, perfusion with subcutaneous injection of immunoglobulin.
Thank you, thank you. So we are running very short of time, and I want to once more thank the presenters and all the participants for your questions. Just before we close the meeting, I would like to address to you the next webinar within this series, which will take place on September the 7th, a Monday, at the same time from 6 to 7 p.m. Central European Time. And the topic of this webinar will be Crossing the Bridge, Tailoring Antiviral Prophylaxis by Linking it to CMV-specific immunity. Information can be found on the ESOT website and social media channels, and registration is now open. If you have further questions about this webinar or the next webinar within this series, please, you may contact askme@esot.org. A recording of this webinar will be made available within the next few days on the platform Transplant Live, and we will also share this on social media once it comes available. I would also like to remind you that this webinar was supported by BIOTEST via an unrestricted educational grant, and I would like to thank you very much for your participation in this interesting, intriguing, and challenging discussion. And also thank our two speakers, Jean Hardwigsen from Marseille and Riccardo Volpes from Palermo, and for their insightful presentations. And from me, from Pisa, goodbye to all of you. Thank you very much to all of you.
Thank you, bye-bye.
Bye.
Bye, thank you very much. Good evening.